Muchas gracias, Lidia, por las instrucciones y por la presentación. Muy buenas tardes a todos, bienvenidos. Les agradecemos mucho la presencia y la asistencia a esta segunda conferencia, como ya nos dijo Lidia, una visión moderna de la epidemia global de diabetes, la Comisión Lancet de diabetes, uso de la información para transformar el cuidado y la vida de los pacientes, que estará a cargo del doctor Edward Gregg, con una introducción del doctor Carlos Aguilar Salinas, quien dirige la Dirección de Nutrición del Instituto Nacional de Ciencias Médicas y Nutrición Salvador Subirán. Como mencionamos al inicio de las actividades de esta serie temática el pasado 5 de abril, este año FunSalud, el Fondo Nestlé para la Nutrición, con colaboradores y colegas investigadores y académicos de diversas instituciones, iniciamos el ejercicio de planear y compartir un conjunto de eventos virtuales organizados en series temáticas para abordar temas relevantes para nuestro país. Esta conferencia forma parte de la serie temática Control y Prevención de la Diabetes y sus comorbilidades, evidencia y políticas públicas para enfrentar las enfermedades no transmisibles en nuestro país. Esto dada la emergencia de salud pública que constituyen las enfermedades metabólicas y sus comorbilidades, y para conocer de primera mano la situación actual y la dimensión del reto en nuestro país, así como replantearnos la prevención, el manejo y la construcción de políticas públicas ante los nuevos paradigmas. Le voy a pedir a Lidia si nos comparte un momento la pantalla para mostrarles que este trabajo no es nuevo y lo iniciamos en el año 2014 y tuvimos esta publicación en enero de 2017. Culminamos el trabajo con esta publicación en la que tratamos de dibujar el panorama de la diabetes en México con la nutrición como eje y abarcando el contexto global, clínico, de salud pública y social de la enfermedad. Esta fue una gran experiencia porque por primera vez nos sentamos a discutir un tema desde diversas perspectivas, con diversas visiones, desde diversos espacios de trabajo y sectores para poder abordar el tema de la diabetes. Y tuvimos esta publicación que se puede consultar, está disponible y que es el origen de esta serie temática y el trabajo que estamos haciendo en este momento. Cuando nos fue presentado por parte del doctor Carlos Aguilar el pasado 5 de abril con la excelente conferencia, fue una gran presentación sobre el presente y futuro de las enfermedades metabólicas en México, oportunidades para la prevención y la atención, nos fue presentada la diabetes como el principal reto de salud pública que enfrenta el país. Nos mostró la importancia de la información generada en México a partir del sistema de encuestas nacionales. Es relevante destacar que la conferencia incluyó los retos y oportunidades en las diferentes etapas de la vida. Y quisiera mencionar que es aquí en donde encontramos la coincidencia y la relación de esta serie temática con otra que está caminando en el mismo sentido que esta y que trata sobre los primeros 1000 días de vida y la hemos titulado de la biomedicina a la salud pública y que estamos presentando como otra serie temática igualmente a lo largo del año. Otro aspecto que quisiera resaltar es cómo la alimentación inadecuada, y nos lo mencionó el doctor Aguilar en su conferencia, es el principal factor de riesgo modificable, por lo que desde un inicio esta serie temática incluye la revisión de temas relevantes de nutrición y alimentación en México, buscando el planteamiento de los nuevos paradigmas de la disciplina en nuestro país. Más adelante, ustedes podrán revisar el programa académico de esta serie en el portal fondonutrición.org, que de hecho esta semana les comento, lo estaremos actualizando para tener el programa confirmado. Más adelante podrán observar que escucharemos la situación de mala nutrición en México, incluyendo los estilos de vida y la perspectiva social y cultural mexicanas. También contaremos con una conferencia sobre nutrición materna como determinante de la obesidad y diabetes en el futuro, explicada a través de modelos animales. Tendremos otra conferencia sobre obesidad durante el embarazo, otra más sobre el estudio de la carga global de enfermedad y continuaremos con una charla sobre la prevención de la diabetes para finalmente contar con otra sobre alimentación y enfermedades metabólicas para finalizar con un análisis y discusión sobre propuestas de política pública. Los invitamos a consultar el programa académico en el portal fondonutrición.org. Ya para dar inicio a la conferencia, quisiéramos nuevamente darle la bienvenida, agradecer mucho la presencia del doctor Edward Gregg y el doctor Carlos Aguilar y procederé a leer las semblanzas. El doctor Edward Gregg es profesor en el Departamento de Epidemiología y Bioestadística de la Escuela de Salud Pública del Imperial College en Londres, al que se incorporó en 2019 como profesor invitado a través de la Royal Society Wolfson Fellowship. Previo a esta estancia, dirigió una unidad multidisciplinaria de salud pública de la División de Diabetes Translacional en el CDC, Centro de Control de Enfermedades, en Estados Unidos, a partir del cual impulsó el rol de la epidemiología para la toma de decisiones en salud pública a través de diversas disciplinas, incluyendo la vigilancia poblacional, ensayos clínicos de efectividad, experimentos naturales y modelaje del impacto en la salud. Tiene especial interés en los factores que subyacen las recientes tendencias de la epidemia de diabetes, así como en el impacto de intervenciones que incluyen a los estilos de vida y otras políticas públicas relacionadas con la salud sobre la diabetes, las enfermedades cardiovasculares y los desenlaces relacionados con el envejecimiento. Ha publicado más de 300 artículos en revistas arbitradas y recientemente fue vicepresidente de la Comisión Lancet en diabetes, dirigida al uso de la información para transformar la atención de los pacientes con diabetes. El doctor Carlos Aguilar es médico especialista en medicina interna y endocrinología, egresado del Instituto Nacional de Ciencias Médicas y Nutrición Salvador Subirán. Es doctor en investigación clínica, director de nutrición del mismo instituto, Premio Nacional de Ciencias 2018, coeditor de la revista ALAD, expresidente de la Sociedad Mexicana de Nutrición y Endocrinología en el año 2009, miembro de la Comisión Lancet para mitigar el impacto de la diabetes. Es editor asociado de aterosclerosis y del British Medical Journal Open Diabetes Research and Care. Autor de 415 artículos en revistas indexadas, y su interés en investigación es el estudio de las peculiaridades de las enfermedades metabólicas en mestizos mexicanos. Muchísimas gracias nuevamente por su presencia y asistencia. Damos inicio a la conferencia y aprestémonos a disfrutar de este evento. Muchas gracias.
En esta segunda sesión de nuestro ciclo de conferencias, revisaremos algunas de las políticas públicas que han demostrado ser eficaces para el control de la enfermedad. En nuestra sesión anterior, identificamos 3 grandes retos para el control del impacto social de la diabetes. En nuestro país, un alto porcentaje de los adultos tienen factores de riesgo que a corto plazo resultarán en un riesgo de diabetes incidente. Por ello, la prevención de la enfermedad debe ser una política pública de amplia cobertura y alta efectividad. Un segundo problema es que la tercera parte de las personas con diabetes desconocen su condición y por ende la implementación de las acciones preventivas de las complicaciones no es factible. Y por último, la efectividad de nuestro sistema de salud es insuficiente. 51% de las personas que conocen su diagnóstico se encuentran en descontrol severo y un porcentaje también muy alto tienen valores altos de presión arterial y de colesterol LDL, los cuales son los indicadores principales para la prevención de las complicaciones crónicas. Diversas agencias, grupos gubernamentales han generado esquemas que sirven como mapas conceptuales para la prevención de la enfermedad y su control. En esta lámina les muestro el esquema que ha generado la Federación Internacional de Diabetes, donde se identifican los puntos claves que deben de ser implementados como política pública para generar objetivos que es reducir los desenlaces relacionados a la salud, prevenir la diabetes tipo 2 y evitar la discriminación contra las personas que viven con diabetes. Como pueden observar del lado izquierdo, una de las acciones son los planes globales y nacionales, que será en buena medida lo que vamos a hablar a lo largo de esta sesión. Para dar pie a la introducción de nuestro conferencista invitado, les hablaré de los esfuerzos que se han hecho en nuestro país en años recientes. Y resalto un esfuerzo generado por la Academia Nacional de Medicina el cual es un documento de libre acceso que ustedes pueden obtener en el portal de la academia. Este documento de postura incluyó a más de 100 expertos nacionales y fue construido con el mayor cuidado para calificar la evidencia. Una vez que se identificaron los artículos relevantes, se establecieron cuáles eran las prioridades a atacar y se identificaron las acciones de política que contaban con la evidencia suficiente para proponerlas. Posteriormente, este ejercicio se acompañó a una reunión presencial para hacer un ejercicio de priorización, identificar las acciones que tuvieran la mejor evidencia y que tuvieran la mayor factibilidad. En este catálogo de acciones se colectan 100 recomendaciones que tienen por objetivo alcanzar 4 metas. Generar un entorno favorable para la opción de un estilo de vida saludable, disminuir el porcentaje de casos con diabetes o en riesgo de tenerla que ignoran su condición y que no llevan a cabo intervenciones para la prevención, la atención con calidad para alcanzar los objetivos terapéuticos y la coordinación eficaz de los cambios propuestos en los 3 objetivos anteriores. En todo momento se identificaron 3 grandes grupos de nuestra población que requerían políticas específicas para cada uno de ellos. El primer grupo es la sociedad mexicana en su conjunto. El segundo grupo son las personas que tienen un riesgo intermedio o alto, en el cual la meta es la prevención de la enfermedad. Y finalmente, el grupo de personas que viven con diabetes, que representan cerca de 8.6 millones de personas. Un mensaje que se deriva de esta lámina es que se requieren políticas transversales. Una sola acción no será suficiente para alcanzar las metas de todo el esfuerzo. Se requieren acciones para estos 3 estratos de la población y la suma de ellas ha demostrado, como nos lo mostrará el doctor Greg, que es posible a mediano plazo tener resultados significativos para reducir el impacto social de la diabetes. La conclusión mayor de este documento fue el ejercicio de priorización que ustedes observan en la lámina. Para cumplir los 4 objetivos, se identificaron de 5 a 6 acciones que se consideraron las más factibles y con la mayor evidencia, lo cual describiré en las siguientes láminas. Para el primer objetivo se identificó como primer paso crear una campaña de concientización que motivara a la población a informarse, pero sobre todo a cambiar su actitud, a tomar una responsabilidad individual para implementar cambios en su estilo de vida. Todos sabemos los riesgos de la enfermedad, sin embargo, pocas personas toman una acción en contra de ella. Esta campaña no se limita a aportar información, debe inducir una responsabilidad individual y social que genere cambios de conducta. Esto debe acompañarse con fuentes confiables de información, estimular la lactancia materna, garantizar el acceso universal a los servicios de salud, considerando a la medicina de primer contacto como el ente primario para coordinar este esfuerzo. En el segundo de los objetivos fue identificado como disminuir el porcentaje de las personas con diabetes que no llevan intervenciones para su prevención. Se resalta que la estrategia que tiene la mejor relación costo-eficacia es la detección oportunista de los casos. Todo contacto con un sistema de salud es una oportunidad para identificar personas en riesgo y para prevenir la enfermedad. También los sitios de trabajo, las escuelas, pueden ser espacios para la detección. Desafortunadamente se han hecho muchos esfuerzos de identificación de personas con diabetes, pero no están vinculados con programas de prevención. El documento propone la estandarización de estos programas, tanto de escrutinio como de prevención. Y finalmente, se recomienda reforzar las acciones para el escrutinio y prevención de las complicaciones a mediano plazo de la diabetes gestacional, un área en el cual México tiene una alta prevalencia, pero que no existen políticas públicas específicas. El tercero de los objetivos es mejorar la calidad de la atención de las personas que viven con diabetes. Se recomienda la adopción del modelo de atención crónica en todas las unidades del Sistema Nacional de Salud. Para estandarizar las acciones, se propone la generación de portafolios, las cuales son secuencias estandarizadas para la detección e implementación de tratamiento basadas en guías construidas con la mejor metodología posible. Se requiere el rediseño del equipamiento de las unidades médicas para que todas cuenten con los recursos necesarios para el tratamiento de las enfermedades metabólicas. Se deben de construir equipos multidisciplinarios en las unidades de primer contacto y reconocer el papel que tienen los educadores en diabetes y todos los integrantes del equipo multidisciplinario en el escalafón de los sistemas de atención médica. Con ello, con este antecedente que hemos descrito a nivel nacional, doy paso a la presentación del doctor Edward Gregg, co-líder de la Comisión Lancet en diabetes, en la cual tuve el placer de convivir con él y ha sido un honor para mí y una experiencia muy enriquecedora. Muchas gracias por su atención y dejo con ustedes al doctor Edward Gregg.
Good afternoon, colleagues. It's such an honor and a treat to be part of this seminar. And I'm going to try to find out how to share my slides here. And as soon as I do, we'll get started. Ernestina, are you seeing that slide now?
No.
No?
Okay. You're not, yes. You share your screen, the green bar.
Okay, here we go, almost.
Okay.
And now?
Now put the presentation mode. Yes, and it's okay, yes.
Yeah, okay. I'll put it in presentation mode. Very good. So thank you for that kind introduction, Ernestina, Lydia, and Carlos. It's really an honor to get to participate in this. As Carlos mentioned, I'm going to share findings from the Lancet Commission work that we worked on together. Lancet commissions they're put out frequently by the journal Lancet, and they're intended to provide a very thorough review of the literature, but most importantly, to be a call to action for a global problem. And I think that whereas all of us right now, we're all in the midst of COVID-19 as our primary pandemic, what we forget is that before COVID-19, diabetes, particularly type 2 diabetes, was arguably the biggest pandemic that we were dealing with. In other words, it was increasing throughout the world in ways that we were really having a very difficult time making a difference. And so this commission was actually pulled together about 4 years ago. It was led by Juliana Chan, and she kindly invited me to co-chair it with her, but we had the fantastic opportunity to have an incredible group of teammates, including Dr. Aguilar Salinas, you see up in the left-hand corner, who played a key role in this commission as well in guiding the messages and the conclusions of, and in addition to that, representing Mexico and representing Latin America to make sure that the context and the problems of Mexico and Latin America were part of all this. So I have the honor of sharing basically the findings. And what I want to do for you really in this talk is go through three things. First of all, I want to talk about the lessons from epidemiology. So as we work through this process of trying to prioritize what the Lancet Commission should do, we looked at the epidemiology. And then the second thing, we looked at the lessons from effectiveness research. And then finally, we came up with a set of recommendations for structural and strategic needs to reduce the global burden. And this last point is important because for diabetes, it's such a broad problem. It has so many different aspects to it that we need experts at all levels. We need basic scientists. We need new development of understanding of etiology, of treatment, new treatments. People are looking for cures. But what we saw our role with this commission was to think about what is really needed to make a difference from a public health standpoint with this problem. And so that's really what we saw our focus here. So first of all, what were the lessons from epidemiology? Well, this slide shows, first of all, what we've seen from the global, what has been shown from the global burden of disease over time. And the left side of the slide shows the leading risks, 30 years ago, and then gradually, and if you look here in this over time, what has happened is high fasting plasma glucose, as of course one of the core aspects of diabetes, has gradually played a bigger and bigger role. And you look now that we see that basically it accounts for the third highest factor behind high systolic blood pressure and smoking. And this has actually been, apart from body mass index, the one factor that has increased the most. And this is one factor that we probably had been had the least success in making a difference on. And part of that is because it's affected by how we live, where we live, our environment. And we really don't, for the general population, we're not really using treatments or approaches or prevention to affect our population levels of plasma glucose in the same way that we are, for example, with smoking. So this is not just a small problem globally. This is one of the core factors affecting all of health, really. The other lesson from epidemiology is that it's hitting every part of the world. This is not just selected segments. And depending on where you are, for example, the Middle East and North Africa are, particularly the Middle East and the South Pacific or the Pacific Islands, are perhaps the areas of the greatest absolute risk. Latin America also is one of the places of greatest absolute risk. Places of greatest increase actually are places like Africa and Latin America as well. The point is, this is a global problem, and that's why we thought of it as a pandemic even before COVID-19. The other observation or lesson from epidemiology is that most of this burden actually comes from low and middle income countries of the world. So if you look at these blue lines below, this is Europe and Canada, United States. In this case, I think they have, I'm actually not sure whether where Mexico is placed in this. I think that it is listed in, well, I'm not actually sure in this, but the point is that the green, orange, and red are in general, the low middle income countries of the world. And this is where the greatest increase in cases are. Now, the other lesson from epidemiology is that there have actually been successes. And we know that there's incredible variation. And we know that in some cases, there have actually been big improvements. We see, for example, this is data that we published from the United States about 6 years ago, showing that the rates of complications have declined for the average person by about 50% in the United States. There's been similar data from the UK and Sweden showing these sorts of improvements. And the reason I share this is because it's an indication that there can be, when the proper preventive approaches are applied, we do have countries and examples where there have been improvements. Now, that said, in the United States, we've actually seen these rates start to go a bit in the wrong direction. So we can never sort of give up on that attention. Now, this data here that we saw, these findings from the United States, have also been shown in a number of other countries. In this case, on the right side of the slide, you see the rates of mortality, all-cause mortality among populations with diabetes at the national level. You can see that the absolute levels are quite different. There's a lot of variation, but for the most part, they improve. However, you'll notice if you look at that list of countries at the top of the slide, that they tend to either be from Northern Europe or North America, or in Hong Kong, if the Asian examples are high income countries. So the point is that we really don't know whether these successes and improvements are affecting other countries. This is a paper that was published just recently from the Pure study, showing that there's actually a great question about whether those improvements are being seen around the world. And this shows here, for example, the incidence of major cardiovascular disease on the left, according to diabetes status. And you can see that among high-income countries, people with diabetes have more than twice the risk, among middle-income countries as well, and then low-income countries. And in each of these settings, you see that people with diabetes have twice the risk of major cardiovascular disease, but you can also see that those rates are much greater in low-income countries. So whether the improvements are occurring around the world is less clear. We also know that even in settings where we've seen improvements in diabetes complications, that the excess risk is still enormous. For example, a person with diabetes has about 5 times the risk of developing end-stage renal disease than a person without diabetes. A person with diabetes has about 10 times the risk of an amputation. And when you look at the levels of care, even in places like United States and Canada and the UK, you still see that most patients do not get all of the recommended prevention that they could get. And this slide shows number of years ago in the United States, that among the 20 million with diagnosed diabetes, that as you scroll across the slide, you see that only 13% of them have appropriate levels of glycemic control, and only, 13 million, only 4 million had actually the appropriate levels of control of hemoglobin A1C, blood pressure, cholesterol, and smoking. So if you can imagine with how valuable these preventive approaches, what could happen or what could be done if we could actually get the population up such that they were all receiving the prevention that they achieved. And we can think of the analogy right now with what we're trying to do to get vaccines to populations. This is a bit of a similar situation in that we can think of these preventive approaches, although not a vaccine, they're highly effective in terms of reducing complications. This is another recent study highlighting how different it is actually from low to middle to high income countries. You can see here, these are the proportions of populations with diabetes that in the blue bars, it's those that are being tested. And then among the red, it's those that are being diagnosed. And then in green, the proportion treated, and then the proportion controlled. And you can see how great this difference is between low income countries and upper middle income. So the other lesson from epidemiology is that diabetes is becoming increasingly a problem of young adulthood. This actually shows the growth of type 2 diabetes in youth and adolescents, and how the absolute numbers in millions of cases have increased dramatically. But what has happened is, as we've had a generation of, really now 2 generations of more obese youth, and they're moving into young adulthood, we have a wave of young adults at a higher risk for type 2 diabetes than has ever existed. So this is one of the major global challenges right now, is what is happening with young adults. And what we know, this is data from Sweden showing how many years of life are lost if you develop diabetes at a younger age relative to an older age. So if you look at the right side of the screen, you see that the expected survival is roughly the same for a person with and without diabetes if you're 80 years old. Even if you're 70 years old, there's a year or 2 loss if you're diagnosed. But you can see that for a 40-year-old, that person is going to lose up to 6 to 7 years. And for a 30-year-old, they're going to lose 8 to 9 years off their lifespan. So in other words, diabetes does its damage with time. And so when you have people being diagnosed at such a young age at an increasing rate, it really has a very bad and ominous prediction for the future in terms of complications. And finally, the other lesson from epidemiology that we might think of as a good one, and that is that epidemiology has shown us that there are many, many modifiable risk factors, things that in theory, if we could change them, they could have a big impact on risk in the population. For example, hip circumference, serum vitamin D, total physical activity, whole grain consumption, smoking, sugared beverages. There are many, many nutritional factors that can actually prevent or increase risk. The point is there are many, many ways that we can tackle this problem, but our public health programs and our clinical systems have not been able to do a very good job on acting on these risk factors. So the question is, how can we exploit and use these risk factors to our advantage to reduce the problem? And so in brief, to summarize briefly here, what we see in high-income countries is a situation like this, where we've seen reductions in mortality, in macrovascular and microvascular complications, and improvements in risk factors. This arrow on the left implies that there's still a long ways to go, and in many settings, they seem to be going back in the wrong direction. And during this same period over these last 25 years, we've seen increases in obesity, in diabetes incidence and prevalence, and lifetime risk. In some places, we've seen some improvements, but the point is these are our challenges for us as we look at this epidemiology. So now, what are the lessons from effectiveness research? What can we do to confront those challenges that I just showed you in the epidemiology? Well, first of all, similar to what Dr. Aguilar was describing, we need to think of this as a multi-tiered problem. We can think of this as a pyramid wherein we have many, many goals. This becomes a challenge because we have to manage many goals at the same time, and sometimes we have to make choices. But at the very top of the pyramid, among that 9 to 10% of the population, depending on where you are, who are diagnosed diabetes, I think it's a bit higher in Mexico now, our goal is to prevent morbidity through optimal risk factor management and screening for complications. For that segment who has undiagnosed diabetes, we want to efficiently detect them in clinical settings. For people with very high risk, measured by, well, there's debate about how best to measure this, but whether it's with A1C or perhaps having a history of gestational diabetes or impaired glucose tolerance, ideally we want to get very focused help for lifestyle change or even perhaps metformin for that segment. But then there's also another segment that's also at high risk due to other factors that maybe don't have such high levels of A1C, but have high normal glucose or several risk factors, and they can be prevented from moving into that very high risk category. And then finally, we have the whole bottom of the pyramid, wherein all of us are at some risk, based on the environments that we live on and live in, and we need to think about how we can change that to influence. This is just sort of another way of looking at the problem. We can think about this continuum of risk here, and you can see though that I should back up here briefly. The longest history of attention to prevention, I would say, has really come in this area of the yellow to purple to white. In other words, what can be done among people with diabetes to reduce that risk of complications and disability? And there's a lot of reasons to do that, of course. Glucose diabetes affects so many organ systems of the body, most classically the eyes, the nerves, cerebrovascular disease, cardiovascular disease, and all of these are preventable in some way. Now, one of the observations and tables in the Lancet Commission describes how powerful of an impact you can have by improving the basics of blood pressure, lipids, and A1C. And that's what this describes here. You see the relative risk reduction, for example, for cardiovascular disease death ranges from a 9% reduction for lowering A1C to a 26% reduction for lowering blood pressure. And you see even greater reductions for stroke and for ischemic heart disease. If you look actually more broadly, though, one of the encouraging things for us with diabetes is that we actually have many, many more evidence-based approaches that can be applied. So with diabetes, we don't have a shortage of evidence of things that we can do. And this is a meta-analysis just published this year from some of my prior colleagues at CDC that shows a meta-analysis of cost effectiveness. And to look at this slide on the x-axis here, you see anything to the left is cost savings, but basically anything below 10 to 20 on that x-axis implies that it's very good value, it's a very cost-effective intervention, and you can see that there are many, many things that can be applied here, from screening for people with undiagnosed diabetes and prediabetes, to applying self-management education, improving glycemic control, controlling blood pressure with ACE and ARB therapy is actually cost savings. And you see even telemedicine for diabetic screening. There are many, many interventions that can be applied. And this is a reminder that with diabetes, although we need to find new treatments, as much as that, we need to apply the treatments to the population that we already know work. That's really one of the main messages of the Lancet. The other observation is that when we think about evidence-based interventions for diabetes, we need to think beyond the individual and how our structures, systems, and our clinics and the way we organize ourselves to apply that. And this shows findings from systematic review showing that there are many, many measurable aspects of the way teams in healthcare systems, the way healthcare system action can be quantified that have a big difference, a big effect on hemoglobin A1C levels. Things like case management, changing teams to have effective sharing, applying electronic patient registries, electronic health systems, audit and feedback. There are many, many approaches here, clinician reminders, self-management, and so on. And you can see virtually all of these have a quite beneficial effect on hemoglobin A1C level. There's other reviews showing that you have similar effects on blood pressure and lipids as well with these same interventions. So what we see here is that going back to this continuum, at the right side, we have many options that can be applied. Now let me turn over to the other segment here. If we look to the left side of the continuum, and we know that there are many modifiable risk factors that if we could change those, we would be able to affect that risk of development of diabetes. The tough question for us now in public health is how do we translate lifestyle prevention trials into scalable programs and translated policies? And how do we take advantage of all those risk factors to make a difference? Well, in this area, when we talk about prevention, this is another area where there's not a shortage of evidence. There's now been many studies showing that if you can identify people efficiently who are at high risk based on having impaired glucose tolerance or perhaps other measures of high glycemia, and you get them into supportive programs for effective behavior change with good maintenance over a year or more, you can reduce their risk by about 50%. Or these were some of the first studies. There have now been many more. These were the first 5 that were done. You see over on the right side of the slide, the effect size. These are quite large effect sizes. We rarely see these effect sizes in chronic conditions where you can actually reduce incidence from 30 to 60%. And it's really a powerful effect that implies that we really should be finding a way to employ them. The other observation from this literature is that they seem to work in different settings. If you look at those studies, although the first ones published were done in Sweden and Finland and then the United States, you can see that they've been done in China, in India, in Japan, and many other places now, and they see similar effects across all of these settings. So this actually has led to attempts to implement it at a national level in at least a couple countries. These are slides showing what's being done in the United States, where the CDC is serving as a recognition center for programs in communities to apply the diabetes prevention models. Similar approach is being used in the United Kingdom right now. And the early findings from these programs are fairly encouraging. This slide on the left shows the United States example, and what it shows is the weight change from these community programs according to the number of sessions attended. And you see that weight change, for example, for those attending half of the program at least have about a 5% weight change. On the right side of the slide, you see what's happened in the UK, and it's a slightly different orientation of the slide, but in this case, they're reporting the hemoglobin A1C change in millimoles that occurs, and you see again this dose-response relationship where if people can attend and you can give them support and incentives to attend, you see a greater impact on hemoglobin A1C levels. In both of these cases, these are thought to turn into and convert into large reductions in incidence of diabetes. The difficulty is that these are the first national efforts that I'm aware of. This is not easy to do, to set programs up like this. And at the individual level, it involves costs. And so there are not many countries of the world that are trying this right now. And so the challenge is to find ways to develop similar programs in different settings that may not have the resources in their health systems to apply it. Now that's the evidence for individual targeted approaches, but there's also growing evidence for population level approaches. And you can see, for example, this is a systematic review from Karen Siegel at CDC showing that actually there are a number of fiscal policies, sugared beverage taxes, sugar taxes. They're of course being tried in Mexico right now, seemingly successfully. Subsidies, and what this CS over on the right is, it actually shows that those studies in general found that it was cost savings. Similarly, this review suggested that environmental changes like getting fresh foods into low-income areas, getting healthy foods into workplaces are also cost-effective. Enhancing physical activity access is not quite as cost-effective, but still may be beneficial as well. Health promotion programs such as campaigns, healthy eating education, it's less clear. But the point is that there are many options for us in population-targeted approaches. So what's the path forward? How do we put these into action, and what should be the priority? Well, I think that really, if you go and review the Lancet Commission, and I would encourage you to do it, it's quite a long document and it covers many, many areas far beyond what I've been covering here during this discussion. However, I think that if you look at it, they tend to fall into sort of three areas of focus or emphasis. The first is reducing diabetes complications and disparities by global improvement of the coordination and delivery of preventive care. In other words, it's really helping to make recommendations for how care can be better organized so that the evidence-based approaches can be brought to the population. That's element number one. The second element is reducing diabetes incidence by changing environments and helping high-risk adults make behavior changes through multi-tiered, context-appropriate strategies. The third approach is to actually modernize population surveillance that through what we call dual-purpose monitoring systems. In other words, surveillance systems, new approaches to data that simultaneously get feedback to improve care for patients, but also monitor health of the population. And so these are really the three big priorities. Within these are some of the recommendations. In terms of improving the gap in diabetes care, it's recommended that policymakers, this is from the Commission, policymakers, payers, and planners increase their investments in diabetes care. They focus on diabetes complications and health system strengthening by doing several things. By establishing hospital-based and community-based diabetes centers and teams that include both professional and non-professional personnel, such as community health workers. I haven't talked about type 1 diabetes in this presentation, but that's another huge priority. It's recommended that all individuals with type 1 diabetes, of course, have access to insulin equipment and education for self-management. And this is a global problem wherein many deaths can be saved or prevented by improving and assuring access. The third priority is that it's recommended to implement team-based approaches that do several things, that risk stratify, that identify the needs of patients, that empower self-management, encourage patient-provider communication. It's recommended that systems collect essential data for quality assurance, and that we promote career advancement for providers, doctors, other healthcare providers who specialize in the concepts of population health and in scaling up data-driven team-based care. So in the commission, there's recommendations for really how this comes about. The right side of the slide describes sort of an example or a prototype model about how diabetes mini teams based in communities or in hospitals can interact with multidisciplinary specialized diabetes centers, and that with those combined, that they should ideally have a linkage to population databases to identify risk factors and trends, a connection to diabetes registers to actually have ongoing monitoring of data on their patients, and a linkage to hospitalization data you see on the right side of the slide, so that our analyses on an ongoing basis can understand how their care is influencing outcomes. And then finally, the bottom part of this model points out that we also need to consider the linkage to self-care and social support, to continuing care, medication access, and to lifestyle changes, with the bottom care typically is done outside of the health system. The left side of the slide describes an example of a diabetes register. This is a more complicated one. We've recently worked with WHO. Some members of the commission work with WHO to develop a simpler one. But the point is that most of the world lacks diabetes registers in clinical settings and certainly at population level settings. And this is an enormous gap in data that is influencing our ability to prevent the problem. So what about prevention? The second key point I mentioned was, how do we enable prevention? What should prevention look like? Well, first of all, it should have multiple avenues of public health action. It should work through health systems, but it should work through health promotion of healthy behaviors, as well as system and population-wide policies. It should be multi-tiered. In other words, it should recognize that prevention is important for people at different levels of risk. It should educate to improve risk factor profiles of the general population, and it should establish effective clinical community partnerships, such as what the UK and US are trying, although we may have to develop different versions to really be able to scale that up in a lot of places of the world. And then finally, we need to develop effective food policies to improve the distribution, basically the options of healthy foods for particularly low-income communities. So this is an example of what we mean by risk stratification. And I think the point here is that we need to think about prevention as applying to different tiers of risk, and perhaps the approach that is used varies according to your tier of risk. So in the ideal setting, people with very high risk level should have access to structured, more intensive programs to help in behavior change to reduce risk, whereas people of high, moderate, and lower risk are perhaps being influenced by broader population-based approaches. Now, what about closing the data gap that I mentioned? Well, the recommendation here is that health systems and public health workers collaborate together to develop dual-purpose data systems to improve quality of care and monitor population health. And these are to do for a number of purposes: to integrate and analyze databases for population monitoring. Second, to be able to analyze real-world data on the effectiveness of interventions and technologies. This is important because we can't assume that the approaches that occur in trials, or that the levels of effectiveness in randomized controlled trials in ideal research settings are going to be the same as they are in real world settings. And this is where the value of real world data and also new methods applying natural experiments becomes very important. The other value of improving our health, our data and our data platforms is to develop accurate but practical models to project cost effectiveness of subpopulations so that different countries, different places can tailor and establish their recommendations that are particularly appropriate for their populations. And then finally, it's important for us on an ongoing basis to be able to detect population trends in diabetes, its complications, its care, its prevention, and all of these, because at the current time, too much of this data is being, too much of recommendations and decision-making is being guided by the data from high-income countries. We're seeing an explosion of data around the world of many, many different types. There's health systems data. There's this EMR stands for electronic medical records, growth of electronic medical records, big data, mobile data, non-health data. All of this is proliferating. And so the challenge for us is how we get this into and we harness this and we make use of this for the purpose of understanding population health, so we can also understand how to target populations better and how we can prioritize our interventions better. This is a slide from this commission showing one model of how a health system or perhaps a country or a region can think about the way that different data systems can be integrated. And the point is that there are multiple levels that ideally, eventually, we want to be able to link together. We want to think about data from diabetes mini teams, from those centers of excellence that we described, registers that can provide feedback, and we want linkages to population data and to hospital so I showed you this slide before to point out that just a minority, it's only about it's less than 20% of the world, the cases of diabetes in the world right now come from high-income countries. Yet those are the countries that have the information on incidence of diabetes, incidence of complications, continuous data to detect changes, geographic variation, and health systems data. And so a key point of the Lancet Commission is that the rest of the world, all of this other area where 80% of the world of the world's cases lie, needs to be able to move in this direction as well. So that's the end for you here. I'm looking forward to our discussion. I hope you'll go to the link that Lancet Commission lies at, and I'm like to thank you all once again for this opportunity. I'm looking forward to our discussion.
Muchas gracias, Ed, por tu espléndida presentación. Ha sido muy completa y ha revisado todo el espectro de las acciones que se pueden implementar en nuestro país. Tenemos un par de preguntas y quisiera iniciar con una que me parece uno de los valores principales del documento Lancet, que es la creación de una serie de indicadores y su vinculación con herramientas electrónicas. ¿Cómo conceptualizas esto para aterrizarlo en un país de bajos ingresos que pueda ser el médico de primer contacto, los sistemas de atención primaria, una fuente continua de información para el desarrollo de políticas públicas?
Sure. Well, this is one of the big challenges because, as I said, only perhaps 20% of the world has moved to the point of having registers for helping with decision making. And in many countries, you have maybe parts of it that are being applied. And I think actually that what needs to happen is we need to start with some case examples and proofs of concept. The WHO right now is initiated a diabetes WHO compact. And with that, I think that what will be released this year is a recommendation for key indicators and also a simple priority list of indicators at 3 levels: at the national level, at health system level, and even at the clinic level. And the point behind this is that measurement drives action. But I think that we also need to think about how we find support, because it's hard for health systems to simply bring in measurement systems when they're stressed and their highest priority is taking care of patients. So we're hoping that there will be leaders that step forward and help this aspect of improving the data gap financially.
Tenemos una pregunta de la doctora Dolores Ramírez, que identifica un área de oportunidad que muchas veces los documentos de recomendaciones no tocan, que es la prevención de la diabetes en sujetos de alto riesgo, pero que tienen más de 60 años, en el cual la pérdida de peso y las intervenciones habituales muchas veces tienen una menor efectividad. Para este subgrupo, ¿crees que se necesitan recomendaciones específicas?
I think this is a very good question. I think that right now, realistically, the structured lifestyle interventions, probably the strongest case for them is in young and middle-aged adults. Now, I think that older adults can benefit from the same sorts of interventions, but their benefits may be a bit different. It's possible that the interventions may be a bit different. Perhaps physical activity would be applied differently, perhaps even the dietary approaches, and the goals might be somewhat different. We're trying to prevent diabetes, but we're also trying to maintain function, prevent functional decline, maintain bone health, maintain mind health. So I think that actually this is an area that actually needs a bit more research into that segment of the population. That said, I think these interventions are generally safe, but they may not have as much to gain as those young adults do who are developing type 2 diabetes at such a rapid rate now.
Tenemos una tercera pregunta en el cual la doctora María Sánchez Aguilar nos pregunta cuál es el papel del escrutinio en cascada en los familiares directos de un caso con diabetes.
Sure, I think that one of the things that it's a way for us to, we want to bring data and make it as, we want sort of to share and make it simple as possible for non-epidemiologists, but we want it to have an impact. And when you look at the benefits and the improvements that happen, for example, with HIV, right? One of the things that they did very effectively was they put goals for nations, for health systems, for clinics, and they used the cascade concept of awareness, treatment, control, and they used that as a goal, and that was very effective. And I think that what we're going to see, and I suspect that WHO will be encouraging us to do this as well, is that they'll encourage us to use goals for diabetes and perhaps other outcomes as well. They might be different levels, of course, but that's where the cascade, it's a very good, I think, an epidemiologic tool to help us understand progress and to drive action.
El doctor Alfredo Ulloa, a quien saludo, nos pregunta, ¿se identificaron algunas recomendaciones para zonas rurales en países en desarrollo o se puede aplicar las mismas acciones para zonas rurales y urbanas?
This is a good question, and I think that this is one of the challenges. To be honest with you, I think actually that there needs to be more attention, perhaps to reviewing how we can do this and what the additional challenges are for rural areas. Particularly, you know, in some settings, you're seeing more attempts to use telemedicine, for example. Now, whether that works and can work in low-income countries that really are lacking resources, I don't know. And I think that this is actually, perhaps there should be a commission on diabetes care for rural areas. Conceptually, most of these recommendations are appropriate, but they may be more challenging in rural areas. And I think that's really what we need to see.
Excelente. Ernestina, ¿quieres hacer alguna pregunta?
Quería hacer un comentario y compartir experiencia mexicana en el sentido de la construcción de políticas públicas, pero principalmente en el sentido de implementar acciones y programas que no necesariamente tienen que ver con la prevención de diabetes, pero que creo que en el país hemos utilizado recursos de todo tipo, talento, experiencia a lo largo de muchos años y ha sido muy exitoso. Y quisiera dar algunos ejemplos. En la Ciudad de México, esto es antes del COVID, en la Ciudad de México, los sábados y los domingos, podemos salir a caminar, a pasear en el centro de la ciudad. El peatón se vuelve el dueño de las calles, el coche es el que no está permitido. Y está totalmente aceptado por la comunidad, por la ciudad, y es una gran oportunidad de actividad física y recreación. No tiene el objetivo de prevenir diabetes, pero funciona y opera. El segundo fue hace unos años cuando se introdujo una legislación o un acuerdo para que pudiéramos pedir agua simple potable y no nos costara un vaso de agua en un restaurante, que no fuera en una botella. No tenía el objetivo de prevenir diabetes, pero funciona y ya forma parte de la vida de todos nosotros. Otra cuestión fue los cambios en los desayunos escolares, en la alimentación escolar, que se introdujeron verduras y frutas, pero principalmente se intentó cambiar el modelo para que fueran comidas calientes, con toda la participación comunitaria. No tenía el objetivo de prevenir diabetes, pero sí de promoción de la salud y mejorar la alimentación de los niños chiquitos. Otro ejemplo son el uso de salero en las mesas, que ya íbamos a un restaurante o íbamos a comer fuera y ya nos costaba trabajo tener el salero. Ninguna de estas tenía el objetivo de la diabetes, sí de promoción de la salud, pero creo que nos perdemos de mucho cuando no unimos todo este trabajo, esta cantidad de recursos y el éxito de estas medidas para guiarlas y conducirlas a algo tan relevante como la diabetes y otras enfermedades crónicas y cardiometabólicas, como me enseñó el doctor Aguilar el otro día. No sé si pudiéramos comentar algo al respecto, pero cuando decimos que no hemos encontrado cómo atender factores de riesgo específico y tenemos todo esto sobre la mesa que es exitoso, creo que estamos dejando de ver el panorama. Doctor Greg.
Ernestina, I think those are excellent points. You know, I'm reminded that every major success, when you see successes in chronic conditions and non-communicable diseases, it's usually not a vaccine. It's usually, it's never one thing. We don't have vaccines for chronic diseases. It's usually multiple factors coming together at the same time. And from different sectors. And I think that you're right. And that ultimately, since multiple factors cause diabetes, we need actually multiple factors to come to actually make a difference on it. And what you described are the examples that can make a difference. The other thing is, the other aspect of chronic conditions is that in general, when you improve one, you're not just improving that one, you're improving others. They have effects on multiple. So I appreciate your comments.
La doctora Ana Lucrecia Elías López nos pregunta si hubo alguna recomendación específica en relación a diabetes gestacional y sus riesgos a largo plazo.
Yes, there is actually there's several in the commission, and I can't remember the specifics except that this was cited as certainly a very important group that to act upon for preventive purposes, in part to prevent risk for diabetes of the woman who has had gestational diabetes, but also because of the way that we can have a positive effect on offspring, and then the risk of development of obesity and diabetes among offspring. So,
aquí en la Ciudad de México estamos iniciando un registro de todos los casos con diabetes gestacional. Lo que hemos visto es que hay una desconexión entre los servicios obstétricos y las unidades de primer contacto. Entonces, para resolver ese reto, se ha creado un registro de todas las unidades médicas de primer contacto y los hospitales coordinados por el gobierno de la ciudad. Y hay un grupo multidisciplinario que está sirviendo de vínculo para llevar a la mujer y su familia para establecer medidas preventivas. Y se está tratando de cambiar la ley para volver obligatoria la notificación de la diabetes gestacional. Que es otra política que esperemos en los próximos años podamos decir si fue exitosa o no. La doctora Silvia Ceballos nos pregunta, en estos momentos de pandemia, ¿qué otros programas se pueden establecer para disminuir el crecimiento de la obesidad?
During the pandemic itself, this has been difficult. I think that what we're going to see in the next few months is the data coming in about what the impact of the pandemic. I have not reviewed it closely, but my understanding is that people have been gaining weight, not increasing weight. And we know that that there's also been a decrease in diagnosis of diabetes. There will probably be a rebound as people get back into health systems, and there will be an increase in response. And I think that increase will be two things. One, it will be those who had not, they hadn't been tested, the decrease in testing, so we'll see a rebound. But we're also going to see some effect of basically the increase in physical inactivity during the pandemic. I think some people, it's been a varied experience. Some people have used the pandemic and they've become healthier, but I don't think we know the effect on the population yet. I think as healthcare, public health and medical professionals, we know what can be done during a pandemic. And we know that in general, being outside, as long as we're doing it alone, does not put us at risk for COVID-19. And so that being outside walking, if we have safe places to walk, is something that we can all do. And we hope that this is a time when people can take the opportunity to learn how to cook and eat healthier foods too. Those are the things we hope that are happening, but we don't know.
Sí, creo que ha sido uno de los mensajes que no se han difundido de manera suficiente durante la pandemia. Esta seguridad y sobre todo con el trabajo en casa y más tiempo para hacer actividad física. Tenemos una pregunta más de la doctora Graciela Cairo, que nos pregunta el balance del costo de prevenir la diabetes contra el costo de tratar la enfermedad. ¿Existe algún análisis que compare el costo-beneficio de prevenir o tratar?
There are a number of cost effectiveness analyses that have shown that in general, preventing diabetes is good value. Now, it does take money, right? If you're going to get high-risk people into programs, there is a cost involved there. But what happens is the delay of diabetes, the improvement in other risk factors reduces the number of events that they have, reduces diabetes incidence, and then gradually it delays and prevents and reduces events. That saves a lot of money over the long term. It ends up, whether it actually saves money, it depends on how long you view and count basically the dollars, but it's good value, and it's certainly good value for the health of the population overall. Certain aspects of treatment are also good value. You know, if we detect retinopathy early through eye screening, or if we improve blood pressure through primary care, those are highly cost effective as well. So I think we have to view across the whole pyramid really when we view the idea of trying to save money.
Una de las lecciones que me dejó la participación en la Comisión Lancet es que creo que hay que aterrizar cosas sencillas con objetivos muy claros y sumar lo más posible. Y yo creo que ahí la tecnología va a jugar un papel fundamental la incorporación a teléfonos celulares, la creación de buenos indicadores que nos permitan orientar qué sirve y qué no sirve. Ha sido un placer tener tu presentación. Agradezco mucho el apoyo de todo el equipo de la doctora Polo y solamente felicitarnos por haber escuchado tan educativa presentación esta tarde. Muchas gracias, Ed, y muchas gracias, Ernestina.
Muchas gracias, doctor Greg. Thank you very much. Thank you very much.
Thank you.
Thank you.
Que tengan buena noche a todos. Muchas gracias.
Igualmente.